So in terms of frailty outcomes, this has been shown to have a post-operative this has been shown to have a post-operative medical and surgical complications with increased length of hospitalization and increased cost. And it's a greater predictor of complications than, it's been found to be a greater predictor of complications than comorbidity, while comorbidity itself was a greater predictor of mortality. So I was also interested in the effect of the age comorbidity and its effect on complications. So I found this large study which was done recently in 2014, which looked retrospectively at 1,201 patients who were done surgery for head and neck cancer. They included those patients who had a surgery that was of duration of more than 120 minutes. And they found that the conclusion of the studies was that specific comorbidities were associated with specific complications. In other words, if someone had, for example, a respiratory comorbidity or cardiovascular comorbidity, post-operatively, they tended to have complications which are related to the initial diagnosis which they had. So these researchers divided the complications into three arms: the cardiopulmonary, neurologic. They grouped them together. And then the one I'm interested in was the fistula leaks, bleeding hematoma. These are surgical complications. And also they looked at infection, it was local and distant. They found that age of more than 80 was associated with cardiopulmonary neurologic complications in those who had already had a comorbidity in those systems. However, there was a significant association of the tumor stage and the length of surgery with surgical complications. They actually quote a figure of about 5 hours, that if the surgery was more than 5 hours, that, and if the tumor stage was stage 3 or 4, that tended to have a significant association with the surgical complications, which were fistulas, leaks, bleeding, and hematomas. What I found also was that the age and comorbidity were not associated with the complications, as I've said, but it's a question of whether maybe there was a selection bias, because we know that before surgery, these patients are seen by a multidisciplinary team. The multidisciplinary team involving head and neck cancer surgeons, physiotherapists, oncology, doctors, physicians, and so forth. It could well be that there was a selection bias, and those patients who were not deemed fit for surgery were excluded. And then they only included those patients who they thought would have a good outcome. Hence, maybe the less occurrence of surgical complications. Previous radiotherapy only they included 77 patients. This is quite a small number, given that they were looking at 1,207 patients. It was not associated with the surgical complications. So the first complication I want to look at is associated with laser surgery. We know that laser surgery is an established treatment for early cancers of the upper airway digestive tract. Its main advantage is organ preservation, improved hemostasis, access to confined areas, precision, and safety. The complications are quite rare in good hands, and they include corneal burns, thermal damage, scarring of soft tissues, and even operator injury, and also airway fire. So in terms of when there is an airway fire, this is usually started off by a spark, by the laser spark. If that happens in theater, the first thing one should do is to remove the source of the fire. If it's depleted, you quickly remove it, and then remove the endotracheal tube, because that is made of plastic. If you don't remove it, that plastic will burn and burn the patient. So quickly remove that endotracheal tube, and then resecure the airway, because the patient is in suspension, it's under GA. Resecure the airway, irrigate the mucosa to reduce mucosal injury, can irrigate with the normal saline, and then a bronchoscopy can be done to assess the extent of the burn. And then post-operatively, the patient has to be observed, given antibiotics and steroids. And then hopefully a lot would have been done for the patient in theater when the airway fire, and not much damage would have been done to the mucosa. To prevent these complications, one should wear eye protection and careful coverage with moist drapes of the patient, and also to protect the airway and the mucosa distally, and also to use an FiO2 of less than 30%, because oxygen tends to be the fuel for the fire. In some institutes, they also use a helium facilitate the delivery of oxygen to the alveoli to reduce the drag of the oxygen in the airway. The second complication, also very rare, is air embolism, and this mostly follows injury to the internal tubular vein, and also those patients who are bleeding from the neck wound. And this results in sudden falls and anti-tidal of carbon dioxide and blood pressure. The lethal dose for humans of an air embolism has been found to be about 3 to 5 mL per kg, or about 3 to 500 mL. So what happens is that this air gets sucked into the internal tubular vein, goes into the right side of the heart, and gets to block the pulmonary vessels, and that pulmonary outflow tract, it gets blocked. And there's a characteristic memo called a Milroy memo, which can be read with a precordial Doppler. This is because of the air bubbles which will be separating from the main air embolus. The treatment of this is to cover the wound with wet gauze so that there is no more air sucking into the veins, and to ventilate with 100% oxygen, apply pressure to reduce the bleeding, and also it helps to reduce the air from being sucked in. Nurse the patient in prevalent position in left lateral decubitus. And left lateral decubitus, because if the patient has got a central catheter, then it is said that you can try to aspirate the air using the already present central catheter. In severe cases, the air can be aspirated from the right side of the heart, and the patient will hopefully not need CPR, but this should be given if it's indicated. Talking of IJV injury, this can also occur at the scalp base, and this is inability to control the tubular bleed at the scalp base. The treatment of this is to peg and maintain pressure during the rest of the case, peg with Cell and then deal with it with needle suturing or whatever is necessary to definitively control it. But the prevention of this is to try as much as possible to have a wide exposure of the tubular vein at the scalp base and the adjacent nerves. Actually, even if it means that the incision has to be extended, or it means that the posterior belly of the digastric has to be transected just to get that exposure, then this can be deemed necessary. Bradycardia and diastole during neck dissection, also very rare. It happens during neck dissection, but it can be life-threatening if it occurs. These are patients who present with severe bradycardia while dissecting over the carotid, and it can occur as part of an exaggerated carotid sinus reflex, also very rare. And it can also happen in a minority of patients who are undergoing neck dissection post-radiotherapy. The treatment for this is to stop the surgical procedure and then give a vagolytic. Normally, the anesthetist wants that the patient is getting a bradycardic, so you have to stop immediately the surgical procedure. And then they give a vagolytic like atropine to try to get the heart rate going again. And then one can also inject adventitia, the adventitia of the carotid valve, to ablate the sinus stimulation using a local anesthetic like lidocaine. Postoperative shortness of breath can be because of a number of causes. There's a number of causes which include stomal obstruction, congestive cardiac failure, atelectasis, and pneumothorax. But the one I'm interested in is the one that can occur in theater, phrenic nerve injury. This patient will present with an elevated hemidiaphragm if that side of the phrenic nerve is injured. And the diagnosis can be made on inspiratory and expiratory films, as well as fluoroscopy and ultrasound scan. The treatment for this, if it's one side that's affected, is supportive. And to prevent this, when one is doing a neck dissection, we have to stay superficial to the prevertebral layer of the cervical fascia. Kylic, this occurs in about 1 to 2% of radical neck dissections, and is most commonly left-sided because of the variable anatomy and fragile composition of the thoracic duct, as you shall see. And it's common in lower neck dissection, usually level 4. Prior radiotherapy and metastatic disease increase the risk of a Kylic. The early diagnosis and management is quite important. As you see, the thoracic duct drains half of the 75% of the body. It drains the left side of the heart, the chest, the abdomen, and the lower limbs. And then the right lymphatic duct it drains 25% of the body, as you see there. And though the diagram there shows the thoracic duct emptying between the internal jugular vein and the subclavian vein, it is a variable. It can empty variably there. It can enter directly into the internal jugular vein, and it can empty into the subclavian vein. So the sequelae of a chyle leak is a loss of protein, loss of fat, a loss of fat-soluble vitamins, trace elements, and lymphocytes. And clinically, this presents like with a hypovolemia. This will cause hypovolemia. It will cause electrolyte imbalances like hyponatremia, hypochloremia, hypoproteinemia. It will cause malnutrition because we're using a lot of protein and stress elements, which can also cause immunosuppression because of the loss of the lymphocytes. It has wound healing complications like delayed wound healing, infection, wound breakdown, formation of fistulas, and fluid necrosis. Intraoperatively, this can be diagnosed by careful examination of the supraclavicular region using the loops. We rarely use the microscope, but there are some institutes who use the microscope. The aim is to identify and ligate thoracic duct if the milky fluid is noted. However, as we know that most of these patients in the first place, they are malnourished and they've been starved for the theater. So it's very unlikely that you'll actually see the milky fluid. So there are some maneuvers which one can try to do. Like you can put them in Trendelenburg position. You can also try to do a Valsalva maneuver or a manual abdominal compression. And as I've said, you should be aware of multiple terminations of the thoracic duct. Intraoperatively, there are a number of things one can do. One can ligate with surgical clips, or you can oversaw that area where the leak is coming from with non-absorbable suture. Also, you can apply fibrin glue or even vicryl mesh. And local regional flaps have been described, like the clavicular head of the sternocleidomastoid muscle or the anterior scalene flap, but this is rarely used because there's a danger there of the brachial plexus when the flap is quite short. And also, we can also use the workhorse, the major neck surgery, which is the pectoralis major flap. So this was the intraoperative. And postoperatively, the patients to diagnose a chyle leak, postoperatively the patient is in the ward, there will be a sudden increase in the drain output. And this can occur especially following enteral feeding, but it can happen even without enteral feeding. You just see an increased amount in the drain. And then in the supraclavicular region, there can be erythema, lymphedema, and palpable fluid collection, and also a creamy or milky drain output. We usually diagnose this clinically in our institute, but you can also diagnose it using biochemical assay if the triglycerides are more than 100 milligrams per deciliter, or the triglyceride count in the drain is more than serum triglyceride level, and also the presence of chylomicrons. The postoperative treatment options, one is to determine whether it's a low output. Low output means less than 500 mils of drain per day, or a high output, which is more than 500 mils per day. But the aim here in the world is to do conservative treatment as much as possible. So the aim, one of the aims is to decrease the flow through the thoracic duct. This can be done by trying to do that by elevating the head, and taking the drains off the suction, and also applying pressure dressings. Also, one can try to decrease chyle production by stopping enteral feedings. Some people stop, some say no, we've got latest feeding, we've got latest feeds that we can actually give the patient even if they have a chyle leak, we can still feed them orally, but then it depends on the institute. And one can also give a diet that is only of medium chain triglycerides as the only source of fat. Somatostatin was advocated for this use because it decreases chyle production by reducing gastric, pancreatic, and intestinal secretions. It does this by causing a constriction of the splanchnic, smooth muscle of the splanchnic vessels, thereby reducing flow. But the problem with it is that it's got a short half-life, and because of that, octreotide has been popularized, has been used because it's got a much longer half-life to try to reduce the chyle leak. Also, one can use a tetracycline cream, which is a sclerosing agent, which works by generating fibrosis to cause the chylic seal. Now, throughout all this, one is to closely monitor fluids, electrolytes, proteins, and lymphocytes, because you can actually lose quite a lot, and the patient can become hypovolemic, can become malnourished. So it's important throughout all this time to be monitoring the drain output and then monitoring also the patient clinical. The last resort is surgical explorations. Now, the criteria for doing a surgical exploration varies from place to place. Some say if you've got an output of more than 500 units per day for 5 days, then you have to go in and try to solve it surgically. Some say no, it has to be more than 1,000. So I was finding this conflicting literature. Some say actually 600, but more than 600 drains per day, then you have to go in and try to surgically deal with it. And but there is general consensus that you have to do surgical exploration if there is no appropriate response to conservative measures. If you're trying to do all those things that I mentioned before, the conservative management, and they don't seem to be working, then you have to go ahead and do surgical exploration. I should say the few, very few ones that I've seen actually didn't need to go for the surgical exploration. The conservative measures work, in my limited experience. If all fails, then the distant management is the services of the interventional radiologists. They can do a percutaneous transabdominal cannulation of the thoracic duct and the sustainer pili. They do this by using lithography and selective distal embolization with coils or tissue adhesive, and the success rate is said to be around 45 to 70%. Cerebral edema, also very rare, it occurs after bilateral neck dissection if both internal jugular veins are ligated. These are the patients who present with facial and eyelid swelling and a secondary systemic hypertension, which is Cushing's reflex. And they've got a mental status change secondary to the cerebral edema, and they can go on and develop bilateral blindness. The treatment for this would be to remove all compressive dressings and restrict fluid. Corticosteroids and mannitol have been used to try to reduce the intracranial pressure, elevate the heat of the bed. And if this is caught early and appropriate management is instituted, intracranial pressure is frequently returns to normal should be expected to return within normal within 24 hours. The next complication in the world is a fistula, which presents with flatulence and erythema of the neck with a low-grade temp. This occurs in up to about 13% of all head and neck cases. About 5 or so days postoperatively, the patient suddenly develops a fever, it's got erythema, and there's flatulence and drainage of saliva. The risk factors for this is previous radiotherapy or chemoradiotherapy, neck dissection itself. Well, comorbid illness, diabetes mellitus, some studies find that it does have it's a risk factor, some are saying it's not a risk factor, so the jury is still out there. Low pre or post-operative hemoglobin levels, this has been found to be a risk factor. And if also the tumor is, if there's hypopharyngeal localization of the tumor and a large tumor size of T4, that's an advanced tumor, and also extended surgeries. The predisposing factors can be divided into patient-related, which are smoking, alcohol consumption, gastroesophageal reflux disease, decreased preoperative hemoglobin, albumin, calcium. This is really a function of malnutrition. These are malnourished patients. So it's not surprising that these are actually associated with, these are actually predisposing factors to developing a fistula. Previous surgical treatment, previous radiotherapy with the sclerosing and decreased vascularization of the tissue, or chemoradiotherapy and tumor recurrence. Disease-related factors that predispose to fistula formation at the stage of the disease, as I've said, the advanced stage being more prone to developing fistula, lymph node involvement, pharynx involvement of the tumor, and treatment-related factors like the margin status, like positive margin, for example, the type and technique of closure, the experience of the surgeon, and if the patient has got preoperative tracheostomy, wound infection, and a recent blood transfusion. So early recognition of a fistula is important. So the treatment for this, the first thing is to a limited opening of the wound and dressing changes with saline. Some institutes use a Montgomery bypass tube. This is a tube that is put in the pharynx and collects the saliva and then directs it into the esophagus. And glycopyrrolate can also be used. Also used this in children who've got drooling to try to reduce salivary flow. And if the fistula is persistent, then one can do a flap closure for this, for example, with a thick major flap. Now, if a patient has a persistent fistula that doesn't seem to be closing, one has to think about what could be happening. And for us, we should try to exclude a cancer recurrence being a cause of the fistula not closing. But however, this can also be because, for example, if there's an abscess, or there's a foreign body, or there's a distal obstruction, or there's epithelialization of the tract, then such fistulas will not close. Prevention, perioperative antibiotics are of use, and meticulous closure of the wound is single versus multiple layer closure. Now, it doesn't mean that if you do multiple layer closure, then you are going to prevent it. But what is important is that that first closure should be a very good one, even if you put subsequent ones. As long as that first one that you use to close them, of course, that should be a good one, it should be a good seal. You can also do a flap reconstruction to avoid tension. A flap reconstruction can be done to avoid tension at the suture line after extensive resection. It's also useful to provide vascularized tissue in radiation damaged tissue. Carotid blowout is also an uncommon event, but the sequelae can be serious. In this study where they looked at 12 of their own patients and 121 patients that were reported in the literature, they found that radiotherapy was the commonest predisposing factor of about 89%, nodal metastasis 69%, neck dissection 63%, soft tissue necrosis in the neck 55%, and mucocutaneous fistulas 40%. This involves the common carotid artery or the internal carotid artery. The incidence is quoted as 3 to 4.5% in major oncological surgery. It's quoted 3 presentations. Type 1 is a threatened carotid blowout. This is carotid artery exposure, which is found in examination or imaging. When imaging, you find that there's some air around the vessels. And the type 2 is impending blowouts. This is presented as sentinel bleeding. And type 3 is a carotid system hemorrhage, which is rapidly fatal. So the risk factors are advanced or recurrent tumors which require aggressive treatment, previous irradiation of the neck, and re-irradiation of carotid artery involving tumors. So if a patient comes with a carotid blowout, the first thing is to stop the bleeding, digital compression. Nest the patient in a supine position and protect the airway. Then you have to put in large bore catheters and do volume replacement, and then stabilize the patient, and then bring the patient to the operating theater. In the operating theater, what one can do, you can do an open ligation of the common carotid artery, though literature says, I mean, in those places where they see this often, they're saying that this is actually associated with a high morbidity and mortality and neurological sequelae, because if you are going to do a ligation on the other side, especially without testing the circulation to the contralateral side of the brain, you can end up with a cerebral ischemia or even hemiplegia and so forth. And this is complicated by flap necrosis, wound infection, hypotension, and cerebral ischemia. So it looks like the operation to actually do an open ligation in cases of carotid blowout are actually becoming less and less and less. The recent data shows that in the US, only 7% of patients with a carotid blowouts actually were done in open ligation. Indications for this are recently performed radical neck dissection and in extensive areas of skin and soft tissue necrosis. So while in operation theater, what one can do is to resect all the diseased artery, do heavy ligature of the stumps, and put on a flap for tissue coverage. Endovascular procedures, this is what is being done. It's a preferred method. This is open ligation. These are embolization procedures and carotid artery stenting. These are done by intervention radiologists. So to prevent this, one must anticipate this in high-risk patients and to avoid trifurcation incision over the carotid sheath so as not to expose it, and also do a demographical in theater or also a vascularized massive flood. So in conclusion, surgery continues to play an important role in the management of head and neck cancer patients. The complications I mentioned here are quite rare. However, they do happen, and their early recognition and management is important for good outcomes. Thank you very much. I will entertain some questions and comments.
Thanks, Raphael. I think a very good overview. I was surprised by that one slide where you said that they found that radiotherapy, prior radiotherapy, wasn't associated with increased complications. Did I understand that correctly? Because we know that if you do a salvage laryngectomy, that your complication rate is higher than primary laryngectomy. So I would be cautious about taking that study as gospel.
Yes, actually it was one of the issues I noted because they had 1,207 patients. And then they only had 77 out of 1,200, they only had 77 who had prior therapy. So that shows that maybe there was selection bias there. Probably they could have excluded most of those patients. Maybe they could tell that maybe these ones are going to complicate surgery. So they only selected those ones who they thought were not going to complicate. So they included them in the study. Because out of 1,207 patients, I don't think it makes sense to have 77. That's less than 10% of patients with prior for head cancer. It doesn't make much sense. So I think that's where they might have selection bias there.
Yeah. And I be cautious about making that as gospel. Yeah.
Okay, I'll open up if there are any questions. You can also type them or ask them. Okay, thank you very much. If there are no more questions, thank you, Prof. So if there are no more questions, thank you so much for joining us. We hope to see you again this Friday for our presentation. Have a very good day. Thank you.
The Friday will be African exercise.